Okay, welcome everyone to I think it's our fifth presentation on all our topics. We're hopefully going to keep doing these every couple of months and all different kind of topics. We do try and send out a little survey afterwards, so if you do kind of can pop those back to us, it's really useful to know what you guys would like to see from us, where we can do better, like how we can improve, what you liked, what you didn't like, all of that. So yeah, if you can pop the surveys back when we send them out, that's really helpful. Tonight we've got an evening that's a little surgery based and then a little bit of ECC as well. First up, we've got Mel, who's going to cover diagnostic imaging and everything to do with that. And then afterwards, I'm going to go through a real trauma case that came into our hospital and kind of the journey that this poor little puppy went through. It's quite a sweet tale and it has a great ending. So that's what we always really like. For everyone who's attending in person, as always, we have our little collector mark cards. So we've got two this time. So if you attended this time, you've done the right thing to get two to take home. One is little skeletons and the other one's directional plans. Just our little gift saying thank you for coming. Well, I hope you all enjoy the evening and take it away, Mel.
Yeah, cool. Hi everyone, and welcome to our radiology evening. So tonight's more about the hands-on side of radiography, and the decisions that we make when our patients are already on the table. We're going to talk about some radiation safety, protecting ourselves every single time, positioning, which is our biggest factor in diagnostic imaging, and image critique. So you can look at the film that you've just taken and decide with confidence whether or not it goes on for interpretation or back on the table. So our learning objectives tonight. So hopefully you should be able to look at any film you've just taken and say without hesitation, kind of that you can send it straight to the vet, or if it gets retaken while the patient is still under. So we're going to go over our radiation safety, so applying ALARA and protecting ourselves and every patient with every exposure. Patient preparation, so making sure it's our right patient, any artifacts, sedation and restraint, any markers and aids that we might need. Positioning, so producing a straight, centered and a good diagnostic quality projection and their correct orientation. To view radiographs and understanding why orthogonal projections are non-negotiable. Spotting any errors and recognizing any common mistakes that we can make. And then self-critiquing as well. So why does image quality matter? So we can miss pathology. So a rotated or blurred image can bury the exact lesion that you are asked to rule out, and it's kind of a very dangerous part as well. And it doesn't look like a failure necessarily. It actually looks relatively normal. Repeat exposures. So every retake means more radiation to the patient, to us, more anesthetic or sedation time, and potentially some more cost to the client. And a delayed diagnosis as well. So a poorly positioned film sends the wrong information to the vet, and the treatment slows down while everyone tries to work off of that film as well. So the diagnostic quality is a decision you make before the exposure and how you prepare and position the patient. It isn't a lucky outcome you discover on the screen afterwards. And I kind of like this quote of the radiograph is only as good as the nurse who positioned it. So if you position it correctly every time, and obviously there is exceptions that some of those patients with very, very difficult anatomy can be quite hard. But if we know that we're trying to do it right every single time, it is hopefully going to be a good radiograph. So touching on ALARA. So ALARA means as low as reasonably achievable, and it's worked through time, distance, and shielding. So in practice, this means 4 kind of habits. So it's PPE always. So every time you're in the room and with the X-ray actually going, like you're taking an X-ray, you need a leg gown, thyroid shields, and gloves. We need to wear our dosimeters and position properly. It does nothing if it's in a drawer outside the room. and it is your personal record if your exposure is ever questioned. And the correct place to wear it is somewhere on the trunk of your body. So whether it be if you've got a breast pocket, pop it there. If you've got a pocket like kind of around your abdomen, pop it there. It needs to be there so that you can have a exposure record. Collimating tightly, and then this pays kind of twice. So you have less scatter coming back at you, and you have a lot more sharper detail on the film, especially with a lot of these new machines and things that are coming out now as well, where they kind of in one way autofocus. If you collimate exactly on what you need to be on, you have a really sharp film. And then minimize any manual restraint. So this is something that you guys can personally control, and it's not one worth arguing for. So sedation isn't only about compliance, and it's a radiation safety tool. So it means that we don't need to then be in the room with the patient. And it also means a still patient means fewer retakes, and it means every pair of hands is outside the room entirely. And as I said, sedation isn't just for compliance, it's a radiation safety tool. And it also means fewer retakes as well. And one thing I would probably say about safety messages, if it's one thing that you take away tonight, you should never have a hand in the primary beam. Not for a quick radiograph, not for anything, because just remember that's then your hand being having radiation through that, and that's not something that we want to keep building up. So then we have our patient preparation. So this preparation is where retakes are prevented. So this is time well spent. So the main 6 things we'll talk about is confirming identity. So the right patient, right limb, right study, and then it's checks against the request. And now I know it sounds very obvious to mention, but it's exactly what slips on a busy day. Removing artifacts, so collars, harnesses, wet or matted fur, ECG leads in the primary beam site. So if you've got, if you're doing a thoracic rad and you've got ECGs on the skin, ideally we need to take them off because they will show up. And each one of them casts a shadow, and it can also mimic or mask pathology. So obviously we don't want the vet having a look at our radiograph and thinking there's something on it, and it's actually an ECG dog. Our anatomical markers. So this is your physical left and right marker that goes into the primary beam before your exposure. You can add it digitally afterwards, but it's not recommended and it's not an equivalent because anyone can then change those. Whereas if it's in the exact film that you've taken, it's not, you can't just take it out. And it also can be challenged legally if anyone was to make a case against you. Having all of your positioning aids out and within reach before you start. So this is so your patient can be held without hands. Deciding sedation versus restraint. Chemical restraint should be your default position. So everyone should go, okay, what are we sedating this animal with? The exception should be restraint and someone manually holding the animal. It shouldn't be the exception. And then we need to measure the thickest part of what we are trying to radiograph and set our exposure before the positioning. So this means as soon as you're ready, you can run out the room and then take your exposure. So exposure factors. So positioning only takes you halfway because a beautifully straight film that is under or overexposed is still a retake. So we have our kilovoltage, which is kVp. This controls the penetration and the contrast. So if we turn it up, the beam gets through thicker tissue, giving you a longer grayscale that you want on a thorax. So you just need to fiddle around with those so if you've got a small cat and you've got a 50-kilo dog, the kVp is going to be very different on those. And we've got our MAS, which is our milliampere seconds. This controls our density. So the more of the MAS that we have, the darker the film. And then the habit is to get the penetration right first and then fine tune the brightness, so the MAS. Sorry. with like when you're getting used to the penetration. If you chase the brightness first by winding the KVP up and down, your films are never going to be consistent. So measure, don't guess. Measure your thickest part of the region with the patient in the position that you're actually going to shoot. A limb measures quite differently when it's extended and flexed. So in a centimeter or two can change your settings quite a bit. So just make sure you measure every time. A technique chart. So this has been validated on your own machine and not what you remember from your last practice. A chart which makes results repeatable between staff and across shifts. If your practice doesn't have one, it's a worthwhile project to take on, but you can also contact the manufacturer and see if they can also give you one as well. So then we have the two failure modes. So undercooked films are very pale and grainy, washed out bone, soft tissue detail simply is absent, and it's often with a speckled look. So this is an example of kind of what an underexposed film looks like. So as we can see, it's very, very pale. We've actually got some like intestines here, which we can't really see very well. We can see the bone, but that's pretty much about it. We can't tell a lot from this radiograph. So this means that it's very much underexposed. And then we have overexposed or overcooked. So this is a very dark, burnt out. All of your thin areas are disappearing entirely. And this is what one of those radiographs looks like. So as you can see, it's completely the opposite. So it's almost like it's burnt through. So we can't see anything. Yep, we can see those intestines still again, but everything else, nothing is kind of shadowed the way it should be. So directional terms and radiographic planes. So these are the words that we use to describe direction, and they matter because the vet will read the label. So we have dorsal and ventral. So dorsal is towards the back or the top or like the spine of the animal, and ventral is towards the abdomen. And these give us our DV and our VD views. We have cranial caudal. Cranial is towards the head, caudal is towards the tail. I always used to think of it as cranial, like cranium, which is our head and our brain. And then when you're on the head itself, we use rostral for our nose. We then have medial and lateral. So medial is towards the midline and lateral is away from it. And this is where the lateral medial limb view gets its name. And then we have proximal and distal. So these run along the limb. So proximal is nearer the body and distal is further away from the body. So the toes are distal to the carpus because they're further away from the body than the carpus is. So the main rule that I kind of want you to take away from this is you name the view by the beam entry point first and then the exit point. So a DV of a thorax is from spine down to kind of sternum. So you're going from the top, so the beam hits the top and then it goes into the bottom. And then if you say it that way, then that's the way that everyone knows. So everyone knows, especially the vet, which way it's penetrated through. So 5 principles now that I want you to apply to every study that you'll ever take, no matter the species or the body part, is keep the patient straight. So rotation superimposes the structures and it mimics or hides pathology. So as you can see on this diagram here to the right, so all the lines are correct, and we already have a slight issue of radiographs becoming magnified as the beam comes down. So if you then rotate your animal, everything then becomes a bit strange and all of the structures don't line up correctly. And it can sometimes conceal a lesion, or sometimes it can even invent one that was never there, which can obviously be very unsafe for our patients. Center on our region of interest. So we want the primary beam to center over the lesion, not over the middle of the animal. Collimate it to that region, and a tighter field is less scatter, better detail, and you'll see all of the borders that matter. Including the full anatomy. So on a long bone, so if we're taking an image of our femur, for example, we want to include the hip joint and the hock underneath that so that we get every single joint above and below that. Don't clip ends again because ends are exactly where fractures like to sit. And then put your markers in the beam as well. So placed correctly on every study with no exception. This is especially important in our like thoracic and abdominal radiographs as well, because we don't always know which side is what, and both look relatively symmetrical, so it's hard to then tell which is which. And then also if you're doing something like a fracture, for example, and both legs look relatively normal, you don't want to clip the wrong leg or do surgery on the wrong leg. So positioning aids. So if hands aren't holding the patient, something else has to be. So these are the tools that we're going to use, and the photograph shows most of them working together on hip study. So foam wedges. These are radiolucent, so they can sit inside the field. You can use them to prop up, derotate or rotate them. And they're also what brings the sternum and spine into line on a lateral. You can also use a trough. This earns definitely its keep on a VD and lateral views. It cradles the patient in a good dorsal or ventral recumbency so they can't roll, exactly like this lovely Labrador in the picture. Sandbags give some weighted support over the limb and the neck, but they are not radiolucent. So that means that if you put them in the primary beam, all you're going to see is the sandbag. You're not going to see any of the structures underneath it. So keep them outside of the collimated field. Otherwise, you're going to obscure what you're trying to show. So you can use some tape as well. Low tack tape gives gentle, steady traction to extend and abduct limbs. May need to mind the coat and the skin, especially on our older or thin-skinned patients. Then we have ties as well. So soft ties pull the limbs clear so nothing superimposes the region of interest. And just one very important thing to take away from this, if your patient is awake or sedated, you should not ever fully tie a patient to the table. And you can use sandbags and things, as you can see in this picture, it kind of looks like it's tied down, but it's actually tied underneath the foam wedges. Held by the sandbags. If your patient is sedated or awake and they move and they are fully tied down to the table, they can then break a limb or hurt themselves and potentially hurt someone else in the process. So if you're using a tie and you have to tie them down to a table, make sure they are anesthetized. And then we've got aids, not hands. So use these so that we don't ever have to be in the room with the x-ray and we don't have to be near the primary beam. So radiographs are a two-dimensional shadow of a three-dimensional patient. So the moment you make that image, depth is gone. Everything in the path is flattened into a single plane, which means a fracture fragment, a displacement, a fissure not sitting directly behind another structure will not show at all, not even faintly, it just will not show. So orthogonal views is views that are 90 degrees apart. And this is for a very minimum diagnostic standard. And it's not a preference. It's not something that you should do in complicated cases. It is very, very much a minimum. And this isn't theoretical either. In practice, the second view routinely changes a diagnosis. It can change a surgical plan and also what an owner is told as well. I would far rather you took one extra exposure and sent a confident, like true answer to your vet rather than taking one radiograph which you were incredibly confident about and the vet then giving a wrong answer to the owner. So our next case, we're actually going to talk about a real case from one of our patients, where the lateral told one story and the surgery told a very, very different one. So this radiograph here, so this cat who is radiographed was presented with a suspected distal limb fracture. On the lateral, as we can see, it read as a very straightforward Salter-Harris type 1 fracture, a very clean physeal injury, very simple to manage, and everyone was very comfortable with this plan. So as we can see in the x-ray, so this is our femoral head here. No, not our femoral head, sorry. The end of our femur going onto our stifle joint, and we've got a lovely fracture here. The next image is a bit gruesome. It is actually from surgery, so if you don't like blood, just turn your eyes away, but hopefully we all do. So this is our intra-op surprise. So when we were in surgery, we actually found that multiple fragments had been sitting directly behind the bone on that lateral projection, completely invisible. So all of the pale pieces you can see a shattered articular surface, which is kind of all of these bits here. Had we stopped at one view, the surgical plan would have been wrong implants, wrong approach. Ooh. I'm so sorry. It's okay. And the second projection, if we had done it, would have shown a completely different view, and it actually would have changed our surgical plan and outcome. So taking a second view generally only takes about 90 seconds. And if the patient is already anesthetized and on the table, it would have shown all of this. So the rule that comes out of this case is 3 things. 2 views as a minimum. Every single time it is physically possible. The only acceptable reason to submit a single view is when the patient would have generally not tolerated the second. And when that happens, get it documented. Believe the harder view. If your 2 projections disagree, and the injury is as bad as the worst one, it is never good as the better one. Don't average them out in your head to something comfortable. And guard yourself against self-reassurance, which is a subtle one. A clean-looking film looks like good news, and good news closes the question very easily. It is not a clean diagnosis, it is half of the information. Those fragments were invisible on the lateral and only appeared once the joint was open. This one habit of taking the second view and trusting it prevents more myth pathology and anything else we will discuss tonight. So I'm just going to go over another case as well where 2 views were really helpful. So here we have a DV of a dog. It's quite hard to see on this image, but does anyone notice anything ever so slightly strange about this radiograph? Can you see anything that's showing up?
The dark circle.
There is a dark circle, yes, but it isn't that. It's kind of hard to see here, but I put an arrow here. So where the arrow is, that's actually a needle, a sewing needle. So from this radiograph, it is looks a bit confusing. It looks like it could be either in the spinal column, could be around the liver, like who knows. However, we then did a lateral radiograph, and then as you can see, it's here. So then that actually shows us it's very clearly in the stomach, which then means we could scope this out rather than going on a wild goose chase of where is this needle? Do we need to do surgery for it? When actually then all we had to do was pop a scope in and then we got it out. So now we're going to go through the 3 main radiographs that you guys are going to take. So each one, just notice what is specific to that region rather than a general view. So we've got our thorax. So at the bottom here, we've got this is our lateral thorax, and then this is our DV as well. So So what we want to do for the thorax is timing is very, very important. So we want to expose at peak inspiration. So full lungs give you the air contrast that make the lung pathology visible. And an expiratory film does not merely look worse, it can fabricate disease and a crowded, patchy lung field that could send your vet down the wrong road entirely. If your patient is anesthetized for these radiographs, do a breath hold, and it will also aid in your vet looking at the image. If they are sedated, try and do it when they're just breathing in. Always two views, a lateral and a DV or a VD, whichever your vet prefers. And again, because pathology hides behind the heart and behind the diaphragm. We want to draw our forelimbs cranially so the humerus are not lying across our cranial lung fields. And we want to check straightness for symmetric rib heads and the sternum sitting over the spine. In the lateral especially, you might need to use a foam wedge and just pop it underneath your sternum slightly, just to stop any rotation. And we need to include the whole lung field. So this is from the thoracic inlet through to the last rib and the diaphragm. So we do have some of the abdominal contents in here, but this is kind of like our diaphragm kind of going around here, and then we can see everything. Then we have our abdominal radiographs. So when you're radiographing the abdomen, it's a very mirror image of the thorax when it comes to timing. So we actually want to expose at the end of expiration. So at this moment, the diaphragm has moved cranially and the abdominal organs have got more room and there's better separation from one another. So inspiration crowds everything together and you lose detail. So you want to include diaphragm to pelvis. Pathology gravitates towards the edges of a study, and clipping the borders is how you miss it. You want two views again. We want a lateral and a VD, because gas, masses, and calculi all shift between projections. Something that reads on a mass on one view can resolve into a gas pocket on the other. With this one, we actually want to extend our hind limbs caudally to clear the caudal abdomen. And you're chasing some soft tissue contrast here. So correct the lower kilovoltage technique matters, along with any planned preparation. So if you can, fasting, an empty bladder or colon, and preparation counts more for an abdomen anywhere else. And I know most of the times you're going to be doing these in practice where you're just like, oh, we need to get an abdominal radiograph, and you don't always get time to prepare and have an empty bladder and things like that. But if you know that your patient's coming in the day before for an abdominal radiograph, try and get them to take them out to the toilet and things before they come in. So this is our abdominal lateral. So as we can see, all of our pelvic limbs are completely out of view and we can see everything really nicely. And then we've got our diaphragm here so we can see our liver, our stomach and everything correctly. And then we have our DV. So our sternum and our spine have completely superimposed on each other. So there's no rotation. We can see all of our ribs and we can see all of our lovely organs. Then we have orthopedics. So as I mentioned before, the golden rule for orthopedics is the joint above and below of the bone of interest. Fracture ends and luxations sit at joints, and if you've collimated them out of the picture, you've not answered the question that was asked. Now, the views must be truly orthogonal, exactly 90 degrees apart. Near enough is not good enough. Rotation, especially in our orthopedics, destroys your ability to judge an ailment and displacement, which is exactly what caught us out on the cat from before. Image the collateral limb whenever you're unsure. So especially if you've got a very fractured bone, always do the collateral limb because then you can see what looks normal for the patient. And then a normal opposite side is excellent comparison for your subtle change, especially in young animals, where you have open growth plates and it looks very alarming. And then if you see an identical appearance on the other leg, you know it's normal for them. Collimate tightly, but don't clip. And also remember these patients are normally in pain. Pain means movement, so use proper analgesia and sedation, and it buys you a sharp, straight film first time. And just checking your tail placement as well, especially on hips and hind limb rads. Sometimes you can see a little tail try and creep into your TPLO rads, or if you're trying to do hips, you want your tail completely straight, which will also help with your hips as well. So this is our lateral, and this is for our stifle joint. And what you really want to note here is that our condyles are completely superimposed on each other, so you can't see like any rotation, and then the same with our tibial head as well. It just looks like one bone, not two surfaces. And then we have our this is our cranial caudal, so you can see all of the joint surface, and it's all very symmetrical and none of it changes. So common positioning errors. So we're going to go through 6 errors that account for the great majority of retakes, and each one has a very simple fix. So rotation. So asymmetric structures, superimposition hides or fakes lesion. So the fix for that one is straighten it with age and check our symmetry landmarks. Under collimation, so we'll have scatter, poor detail, and the area of interest borders aren't well defined. Tighten the field to our region of interest. Only one view, we get our depth loss and pathology hidden behind bone. Always take 2 projections. Clipped anatomy, so the fracture end or the joint sits out of the film, remembering joint above and the joint below. And then for our thoracic and abdominal radiographs as well, with our thoracic ones, making sure we get everything in, including past the diaphragm, and then for abdominal ones, going that little bit further up as well. Motion blur, so the loss of sharp margins, and this is when the patient moves. Sedate the patient if we can, and expose on a correct breath phase if we're doing our chest or our abdomen. If they're breathing very, very quickly, we will get a lot of motion blur. And no or the wrong marker, obviously it means we have an ambiguous side, and it is a medical legal risk, and put a physical left-right beam marker in the beam on every study. So this is a tool that I want you guys to take away, and running it kind of takes about 10 seconds in your head. So kind of want to work on this list every single time you take a film and before you submit it. So we want to make sure that it's the correct patient and has the correct anatomical marker in it. 2 orthogonal views. Region of interest is centered. Everything is collimated. The patient is straight and there is no rotation. The correct exposure, full anatomy included, and no motion blur or artifacts. Now, diagnostic means that the vet can answer the clinical question from this image without guessing. Not that it just looks reasonable, and not that it's the best of the 3 that you took. And the ergonomics settle the argument. Retaking now while the patient is still under anaesthetic or sedation and they're still on the table is always going to be cheaper than the owner coming back again next week because we need some more information. So now we're going to go through this radiograph together. And we're going to put everything that we've learned into practice. So I want you guys to imagine you've just taken this radiograph, and I want you to think about, is it acceptable to give to your vet? So we have these little points to work through. So is it straight or is there any rotation? Is it centered and collimated? Is all the full anatomy included? Does it look like it has the correct exposure? Is the marker present? And do we have a second orthogonal view? I'm going to give you guys about 30 to 40 seconds just to have a quick think about this. And then we're going to go through the radiograph together. But just have a quick think about all the points. Okay, so what went wrong with this film? So we'll all kind of go through it together. So we'll go through that list of, okay, and please feel free to shout out. So do we think that the patient is straight, or do we think there might be some rotation? Yeah, there is some rotation. So the rib heads are not superimposed. So as you can see, it's very hard to kind of see on this picture, but you can see here you've got one rib coming down, and then you do have another rib kind of extending there. So we're not straight. Do we think that this image is centered and collimated correctly? No. Yeah. So we've clipped the field quarterly, so the last ribs and the diaphragm is completely cut off. So we don't get to see all of kind of what would be kind of here at all. Is the full anatomy included, do we think?
No.
No. So our forelimbs are left back, and our humerus is over our cranial thorax. So we really need these limbs to be pulled right forward so that we can, so our thoracic inlet is about here. So we really have missed out on quite a lot of this thorax. Do we have a marker present? No. So we don't know which side of the chest is worse. So oh, no. Why does that come up? Oh, I've missed one, sorry. So no left right marker. Do you think we used the correct exposure on this patient? No, we did not. No. And we also exposed on expiration as well. These lungs are very underinflated and there is poor air contrast. And this is what it should look like. So just highlighting the differences. So this is a very well exposed thorax. So our forelimbs are completely moved forward. So we can see this part of the lung, which we couldn't before. Our heart and our lungs look a lot brighter, and you can see all the different densities in the soft tissue. We now have our last ribbon, so we can see all of this caudal thorax, and all the rib heads are now in line, so we know that there is no rotation. So our take-home messages is, so if you forget everything else for tonight, try and keep these 5 things in. The top one is no hand in the primary beam. Sedate, use aids. We want, again, our LARA to be our habit, so as low as reasonably achievable, not just a policy on the wall. 2 orthogonal views always, and this is your single most reliable defense against missed pathology, and in our case with our cat it is definitely the proof. And we want straight, centered and collimated views. We want the joint above and below, and never to eclipse any anatomy on a long bone study, and critique before you submit. We are so able to critique every single radiograph that we take, and nurses are single-handedly able to do them on their own and then get the vet in afterwards. So we can send really, really good radiographs to our vets every time. Does anyone have any questions? Cool, thanks guys.
Thank you. We'll just take a short break while we get set up for the next one. There are some bathrooms, and everyone needs a break just down on the right. And please, still more pizza, so help yourself. Watch out for sneaky pepperonis. Everyone online, we're just going to pop you on mute for 5 minutes, and then we'll be back. Alrighty, we'll start with the second presentation. So good evening, everyone. Thanks for having me. Tonight, we're going to go through one of our more memorable orthopedic trauma cases we've managed here at Medipause. So this is Sibilance. She was a 4-year-old borzoi who presented with a grade 2 open radius and ulnar fracture. And what started as a completely routine trip to the park ended in tragedy for poor Sibilance. What looked like at first a straightforward trauma case turned into months of treatment, multiple surgeries, and a significant complication, but ultimately a fantastic outcome, which is what we all want to hear. Throughout tonight, we'll follow her journey through the moment she came in through the emergency door, all the way to her full recovery, and at every stage, we'll highlight where the nursing care made the difference for Sibilance. So before we start, here's what I'd like you to take away tonight. By the end of this talk, you should have a clearer understanding of nursing priorities when managing an orthopedic trauma patient. We'll cover emergency stabilization of an open fracture and the anesthetic considerations of a long orthopedic procedure, perioperative and postoperative nursing care, and the recognition and management of implant-associated infection. And most importantly, I'd like you to leave with some practical tips you can apply in your own patients tomorrow. So let's meet Sibilance. I think she's a cutie. I really liked this dog. So she is a 4-year-old borzoi who weighed 21.2 kilos. She's otherwise fit and healthy with no other significant history before the injury. So unfortunately for Sibilance, she was at the park chasing a ball. She jumped off a bench and down roughly about 2 meters from a seating area, missed the step and landed very heavily on her right forelimb. Her owner heard her yelp immediately and found her completely non-weight bearing with an open bleeding wound and visible exposed bone. So it's a bit of a trigger warning with that picture, but that was when she immediately came in. To their credit, they didn't wait around. They brought her straight in, and with that early presentation, that genuinely mattered for what came next. So now I want you to put yourselves in the nurse's shoes for Sibilance at this moment. You've taken the phone call. You've been told the dog is arriving with an open forelimb fracture and exposed bone. What are your priorities? What do you prepare? What do you first do when she walks through the door? Minimize bleeding. Anything else? Okay. Yep. So most people do go straight to the fracture because it is extremely dramatic. It's confronting and it's the thing that we can all see. But our first priority is always the patient, not the injury. So we always want to start with our primary survey when they first walk through the door. So airway, breathing, circulation. She is a healthy dog and everything like that, but we want to make sure that those things are completely okay before we start looking at her leg. So a dramatic fracture is always a good way of distracting you from something else that may actually end up going very poorly and might kill the patient. So in Sibilance's case, she was bright and responsive and hemodynamically stable. Her perfusion parameters were normal, and there was no evidence of thoracic trauma or significant blood loss. So she was good, but understandably very painful. Once we confirmed there was no immediate life-threatening injuries, our attention could safely shift to stabilizing the fracture and getting on top of that pain. So with the primary survey complete, we moved to emergency stabilization. She received opioid analgesia straight away because in a patient like this, the pain relief is not something we want to wait. An intravenous catheter was placed, blood samples were taken and collected for hematology, biochemistry, and intravenous antibiotics were started as early as we could. The wound was gently washed with some saline to remove any gross contamination and then covered with a sterile dressing to prevent any further contamination. And only then did we obtain radiographs to see what was happening. The point that I'm trying to make is everyone naturally focuses on trying to repair the fracture, but infection prevention beginning in these moments when the patient walks through the door, that first sterile dressing, that first dose of antibiotics are nursing interventions that influence the outcome of the next kind of weeks and months, really. So these are her radiographs. They are
quite dramatic. So before we go for a full diagnosis, what would concern you in this case? Sorry, what's that? Potentially, yeah, she could have some nerve damage. It's quite a distal fracture, which are always a bit trickier to fix. I think all surgeons would say that. So what these radiographs show is a grade 2 open fracture. So the images confirmed a short oblique distal radial ulnar fracture with cranial, proximal, and lateral displacement of that distal fragment, and critically, the open wound communicating with the fracture site. So the key message on this slide is because the fracture communicated with the outside, this wasn't simply just a broken bone. It's an orthopedic emergency with high risk of contamination, subsequent infection, and it does need surgical intervention on that day. So why do we treat open fractures so differently? There are really two problems running in parallel. The first one is mechanical. We've lost skeletal stability that we need to restore it well enough for the bone to heal. The second is biological. The soft tissue envelope has been breached, bacteria has been introduced, the blood supply to the surrounding tissues may be compromised. Those two problems do kind of pull against each other a little bit. So the rigid fixation gives us the stability, but implants also give the bacteria a surface to colonize on. So our goal from this point forward was to restore stability while minimizing infection risk, and every single decision we made weighed against those two things. Before theatre, we needed an anaesthetic plan. So on paper, sibilance is an ideal anaesthetic candidate. She's young, healthy, she's got no comorbidities, but there are two things that are working against us. Firstly, it's a very painful injury. An inadequate analgesia in an orthopedic patient may mean higher inhalation requirements, which leads to more cardiovascular depression, and then you're probably going to have a rougher recovery on the other end. Secondly, orthogonal plating can unfortunately be a very long procedure sometimes, which brings us to a risk of hypothermia, hypotension, and prolonged recumbency. She is also a sight hound, which is worth flagging for her. So she's got a lean body condition and minimal body fat. So she does have a real tendency towards hypothermia. So the question we asked ourselves was, how do we reduce our inhalation requirement while still providing excellent analgesia? Does anyone have any ideas how we could do that? Good pre-meds, always, yep. Blocks, yeah, perfect. So this is the protocol that we settled on, and it genuinely was a multimodal approach. She was pre-medicated with a sedative to reduce stress and lower our MAC, and we also combined it with an opioid for analgesia. Induction was propofol titrated to effect and maintenance with isoflurane. We ran a ketamine CRI intraoperatively to manage wind-up and further reduce our inhalant requirements. And we also did a run block. So it's a radial, ulnar, median, and musculocutaneous block. And the was great perioperative analgesia for that distal fall-in. So the block was probably the single most valuable part of the plan. It meant we could run at a lower vaporized setting, and she was far more comfortable in recovery. The blocks that we use here, we generally use bupivacaine, which has an 8-hour duration of action. Thank you. My brain just left the building. So yeah, 8-hour duration of action. So even if we're in surgery for 3 hours, we've still got 5 hours worth of pain relief post, which is amazing. So as nurses, our role here extended well beyond watching anesthetic depth. We were responsible for active warming and temperature monitoring, blood pressure support, fluid management, anticipating our surgeon's needs, and keeping her stable across a long procedure. So with the plan in place, sibilance went to theatre for definitive repair. Because this is a grade 2 open fracture, the surgery started well before the bone. The wound required thorough lavage and debridement to reduce bacterial contamination and remove any devitalized tissue. Only once the wound was clean did the surgeon proceed to open reduction and internal fixation using orthogonal plating to restore the alignment and provide rigid stabilization. From a nursing perspective, this is where the detail mattered. Patient positioning, maintaining strict asepsis, active warming, hemodynamic monitoring, and ongoing analgesia across the whole procedure. This is our immediate post-op radiograph. As you can see, we got some excellent alignment and stable fixation of that distal radius. And the second orthogonal view confirms the implant placement, just like Mel was talking. So you can see the 2 plates on there instead of just seeing just one big plate down the front. And here Sibilance is still under anesthetic for her x-rays with the limb appropriately bandaged following surgery. And at this point, we were really optimistic that surgery had gone well, fixation was stable, and she will recover very smoothly. I want to pause on theatre because this is where all the nursing detail quietly determines the outcome. Positioning and padding matter. We're protecting an injured limb and all the pressure points of a lean, bony sight hound for a long procedure. Asepsis is ours to own. It is an open fracture and already has a bacterial burden. Fear to discipline is infection prevention. Temperature is the one thing I'd flag the hardest. Minimal body fat, a long surgery, cold lavage fluid, and clipped skin. Active warming needs to start before she is cold, not after. Alongside that, we're managing blood pressure, fluids, and anesthetic depth and anticipating what the surgeon needs before they ask. And analgesia continues throughout. The block and the ketamine CRI only help if we keep the plan running. So Sibilance recovered smoothly from anesthesia and was transferred to ward. Her recovery vitals were reassuring. Mentation was quiet, alert, and responsive. Her temperature was 38.6, which was a massive win. Usually, sometimes they come out so cold. Heart rate was 68, respiratory rate 24, and blood pressure 128/48 with a mean of 74. Our nursing priorities now shifted to 4 things: multimodal pain management, close monitoring, limb and bandage care, and early physiotherapy. Particularly, that meant regular pain scoring rather than waiting for her to tell us that she was sore, checking the toes for swelling, temperature, and comfort, watching for strike through or slippage of the bandage, and monitoring appetite, urination, and mobility. After a couple of days, she was discharged home with analgesia and antibiotics, and she initially appeared to be progressing exactly as we hoped. If there is one skill in this case that belongs to the nurses, it's this. Every bandage check is a clinical assessment, not a task. Toes get checked for swelling, temperature, and comfort of every single time. We're looking for strike through, slippage, odor, or moisture, any of which can mean trouble underneath. Changes can happen under strict asepsis. The wound gets described in the record each time. Photographs are enormously helpful because gradual change is hard to notice day to day, but very obvious in a series of images. And the most important point, escalate early. New discharge, increased pain, or a patient who was improving and is now not, it's never just the bandage. In this case, it was exactly those findings that identified a potential implant infection later on. So then 1 month later, everything changed. So Sibilance was doing really well, but then she was on track, and then she had another traumatic event, unfortunately. So while she was at home, Sibilance was in the back garden and she spotted a possum. She chased it. She attempted to jump a 6-foot metal fence and landed awkwardly on that operated limb. Her owners brought her straight back to Medipause for an emergency consultation at 11 o'clock at night. Bless them. So on examination, she had a small amount of blood oozing from her foot and some mild discomfort over her carpus. She was toe touching, but according to the owner, she had already improved compared to when she immediately had the fall. So naturally, our immediate concern was implant failure or a new fracture. So imaging was performed. Unfortunately, everything remained stable. There was no broken plate. The fracture was good. There was no new fractures. So Thankfully for the owner, they just elected for an analgesia trial at home with clear instructions on what to watch out for and strict rest. But unfortunately, it's still not the end of poor Sibilance's story. So fast forward, 1 week after her course of antibiotics finished, this is the point in the case where things started to go wrong, and it's worth noting the timing. Problems appearing shortly after antibiotic stop should always make you a little suspicious that something else is going on. So sibilance represented, and these are our findings. Lameness had increased on that surgical limb. There was swelling around the surgical site. She was painful on palpation, and discharge had developed at the surgical site. So looking at all those findings, what would be top of our differential list? So our concerns would be, we could also jump to seroma, suture reaction, delayed union, implant loosening, which are all reasonable, but you got there first one, infection. So our biggest concern was that after our antibiotics have stopped, we do have an implant associated infection. So the good news is that the implants remain stable and the fracture healing was progressing. So rather than rushing her straight back to theatre, the team elected to begin targeted antibiotic therapy while monitoring her response closely. This is an important teaching point that not every implant-associated infection requires immediate implant removal. Clinical judgment and above all, fracture stability drive that decision. Removing implants from an unhealed fracture creates a much bigger problem than the one you're solving. Sibilance remained on antibiotic therapy for another month, and her clinical signs improved after we got that infection under control. However, those implants still represented a potential reservoir for persistent infection, so the next step was a carefully planned staged removal. So these are some more radiographs of sibilance, one pre-op and then one post-op. So once we could see on the radiographs that we had quite a bit of fracture healing there, the first implant was removed. So we removed that little accessory plate on the side. So the aim was to kind of reduce the bacterial burden while still maintaining enough stability for bone healing to continue. It's just a staged and balanced approach to let us treat the infection without ever compromising the fracture site, because we don't want her to fracture again and have to go through all of this all over again. And then 3 weeks later, repeat assessment confirmed ongoing healing. At that point, remaining implant could safely be removed. Following that second surgery, sibilance continued to recover well. The fracture site remained stable. Limb function kept improving, and there was no evidence of persistent infection. So luckily, we managed to get the plates out, and they were what was harboring all that nasty bacteria. And I just love this image of her 4 different views that we have. So we have literally from fractured all the way to absolutely fixed. And yeah, so on the far left is where we started, the short oblique distal radial ulnar fracture on presentation with the distal fragment displaced and the wound communicating with the fracture site. The next image is following the first surgery where the fracture reduced and stabilized. You can see the alignment restored and the implants holding it there. The third image, partway through our staged implant removal, once we had radiographic evidence of healing, we could start reducing that bacterial burden without losing our stability. And on the far right is our endpoint, implants removed, fracture healed and remodeled, and no radiographic evidence of ongoing infection. What I'd like you to take from this progression is that recovery here isn't a single moment, it's months of incremental change, and every decision to progress was guided on repeat imaging alongside what the nursing team was seeing clinically day to day as well. And this is sibilance today, back to herself, comfortable and doing what got her in trouble in the first place. So let's finish with the wins. The infection is completely resolved. The staged implant removal was successful. She returned to comfortable limb function and her long-term prognosis is excellent. After months of treatment, multiple surgeries, and an enormous amount of patients from both her owners and our team, sibilance made a full recovery. And I'd like to emphasize this outcome wasn't achieved by surgery alone. It came from teamwork, staged decision making, and consistent, dedicated nursing care over a very long period. So if you take nothing else home tonight, take these 5 things. 1, treat the patient, not the fracture. The dramatic injury is very good at distracting you from the thing that could potentially kill your patient. 2, infection prevention starts at the door. The first dose of antibiotics and that first style dressing influence what happens months later. 3, in long orthopedic anesthesia, temperature and blood pressure are yours to protect. Start warming early. 4, pain score on a schedule. Our patients do not need to tell us whether they're comfortable or not, and a comfortable patient recovers faster and moves better. 5, you will usually be the one who sees the infection first because you're the one doing all the bandage changes and daily assessments. Trust what you're seeing and speak up early. Thank you all for listening, and I'm very happy to take any of your questions. Anyone has any? Alrighty. Does anyone have any questions online at all? Alrighty. Well, we're gonna stop the recording and end the Teams meeting. Oh, is there?
Oh, sorry, I have a question if that's okay.
Yeah, for sure.
It's just going back to the very first part 1 of our X-ray session. Do you have any
Mel.
tips? Oh, thank you.
Sorry, let me pull her over.
Thank you.
She's the X-ray extraordinaire, not me.
Oh, thank you.
Hello.
Hello, hi. I was just wondering, because you said that when you're taking like like limb x-rays and stuff, like for example, the femur, like take like the full like the full long bone, like, not only just take the femur, but also like take the hip joint all the way down to the hock. Do you have any tips on like, what happens if you're presented with like a very large long-limbed um dog? It's usually a dog, and how to fit that all in one x-ray image, or would it have to be a two-part situation?
Yeah, so try if you can, obviously, depending on how big your collimation settings are on your X-ray, you try and fit it all in on one or as much as you can. Like take an X-ray first of where you think you're going to get everything, and then see how you get on. A lot of new X-ray heads as well are slightly movable, so you can kind of turn your X-ray head slightly, and you can normally fit the bone in that way. But if you're really, really struggling, then yeah, definitely just get it in 2 series. So collimate quite tightly and then kind of put a marker on roughly where you've stopped. And then you could just extend that so then you get the full bone.
Okay, that's interesting. All right, great. Thank you. And also maybe just one more thing as well. Like because we're starting to get in, like our clinic's starting to get into like more orthopedic proper x-rays and stuff like that. When you're presented with like a very fat and very furry patient, do you have any tips on how I can get that 90-degree angle like really well? Because I'm just always deceived every single time I try and get that angle. I because the patient's just so fat or too furry, and I get deceived so much.
You know what, funny enough, we actually had a very similar patient in today. We had a nearly 90-kilo Newfoundland in. Yeah, and he was incredibly difficult to x-ray today. But with your orthopedic x-rays, when you're trying to get these very fluffy things, your hands are a good thing to use while you're collimating. So with your hands, feel where that bone is. And what I sometimes do is, and this isn't with the like taking the x-ray at all, but a lot of your x-rays should have some kind of X on them. I'll put my hand underneath the light and see where that X is and just try and line that up where I think that the fluff isn't, and where that bone is. And then that way you can then collimate to there. With the very chunky things, if you're trying to do orthopedic radiographs, Sometimes their chunk can help you, but also sandbags and what are they called? Wedges, thanks. The wedges are your best friend. So you might have to tilt them slightly.
Okay.
And don't get me wrong, I've probably done a 4 or 5 radiograph series on one view because I can't get one.
If their belly's getting in the way, I've used a slip lead in the past to give them a bit of a tummy tuck,
Yeah.
put it round their abdomen and tuck their tummy up, unfortunately for them.
Yeah, or tape as well can sometimes be your best friend. If you haven't got access to a slip lead, you can,
Yeah.
especially sometimes with male dogs as well, if they're slightly bigger and they've got a relatively large penis, you can kind of tape that out of the way. That also helps too.
Okay. Excellent. Great. Thank you so much.
Oh,
And then there was a
good.
question on the
Yes,
chat
I've got
as
it
well.
here. So there was a question in the chat as well. So are bozois similar to greyhounds where they can become hyperkalemic under GA? Not to my knowledge. I know that greyhounds occasionally can be a little funny, and I know they are sight hounds and are similar, but maybe I just haven't anesthetized enough bozois to notice it. But as far as I'm aware, they do not. But I can check on that and get back to you, Naomi. Yeah. Do we have any other questions at all? We're all good? All right. Oh, sorry, Naomi's typing. She says thanks. All right, so I'm going to stop the recording and we'll finish up for the night. But thank you to everyone who came online and in person. Find my mouse. My mouse. Oh, there it is. That's my mouse.
It's on here, so go backwards.
I know, I need to go.
It's on my screen now, so I think that's also.
There it is.
What's up, girls?